we're going to talk about feeding in somebody who has severe Alzheimer's. And no matter whatever the situation, it's always a very contentious, controversial, stressful topic to talk about feeding in somebody who is not eating. And so we usually have two choices, okay? There's only one choice on the advanced directive, and that's not to feed or give fluids at all. And so that's where it becomes concrete. No more fluids or feeding after this point in time. I just don't want any feeding at all. Then there's the other alternative that most of our patients are going for is comfort feeding only. But the bad thing about comfort feeding is that it's not only very stressful and a lot of work, but it can prolong a person's life for years. And one of the things that patients will always say is, please, if I'm not feeding on my own and I'm have no quality of life and there's no more reason for living, then don't prolong my life. And yet, when we do comfort feeding only, they can last for years past that. And if they saw themselves in that position, they would always say, I don't want to be that person in that bed being fed that way. And yet we do it for whatever reason. And it's called comfort feeding only. But the bad thing about comfort feeding only, it's proactive, meaning that we do it no matter what. Because it's very subjective what comfort means, and is it our comfort, is it the patient's comfort, whose comfort is it that we're trying to treat? So we may wake up a person from sleep to feed, a person may not be able to swallow and they're gagging and choking, and we've seen that in our patients. Or the other thing is that it will take a caregiver hours to feed. I would go talk to people at nursing homes. Is Mrs. Jones eating? She eats, but boy, it takes us about an hour to feed her this little bowl of food. And it just brings a lot of stress and agony for a lot of people. But again, it prolongs this person's life who doesn't have a good quality of life. And so are we doing the patient a service by doing that when they've told us, I don't want to be living like that? Okay. So there's something new that they're thinking about, and it's called minimal comfort feed. Okay, and so I'm going to kind of give you the three scenarios, and I'm just going to read it. So comfort feeding only, by definition, is no more food and liquid than is comfortable. But that is a routine thing that is prolonging life. We're giving it like breakfast, lunch, and dinner on a routine basis. The appropriate person is a person with advanced dementia who did not previously express a wish to avoid living with advanced dementia. So that's most of our patients. They're under comfort feed only. And so we're working really hard, even if it's a little bit, to get that food in 3 times a day or whatever we think is reasonable. The time to death is up to years, and prolongs life to the extent possible, yes. Scheduled hand feeding, yes. So again, it's on a clock like our meals. And so if they're not awake, a lot of times caregivers will wake them up to feed. Okay. And as far as informed consent, you don't need anything. It's what we do the best we can. Now, supporting eating and drinking by advanced directive, by definition, is no food or liquid at all. The appropriate patient is a patient with advanced dementia who has written directives specifically rejecting any oral nutrition and hydration. Time to death is days, and prolongs life to the extent possible, no. And it does need consent that to do that. So that's why it's on the advanced directive. Now, advanced dementia is what we would normally call somebody who's 7A by a fast scale or farther along. Okay? So somebody who's having early dementia, we can't do that. But somebody who's very advanced, so 7A on the fast scale, is who we can kind of make these choices for. Okay? Now, this is minimal comfort feeding. This is the alternative, the hybrid or the compromise that might be better for the caregivers as well as the patient. And again, it's called minimal comfort feeding. By definition, only as much food and liquid as necessary to avoid discomfort. The appropriate patient with advanced dementia who previously expressed a wish to avoid living with advanced dementia. Time to death, weeks to a few months. Does it prolong the condition? The answer is no. Scheduled hand feeding, no. So they're not on a clock. We only feed them when they express some kind of symptoms or there's some perceived notion that they're hungry or thirsty. So if they're not expressing that, we don't wake them up, we don't force feed them, we don't spend hours of time giving them food. If they stop eating, that's okay. We're just giving them food to keep them comfortable, not to sustain anything, but just to treat their symptoms. And the informed consent is moderate. So you just have to train the caregivers and the families and the nurses to be on the same page, and this is what we're going to do, and this is our goal. Okay. So in our minds, we think we're doing the minimally feeding type thing, but really, because of guilt or facility regulations or obligations or whatever, even caregivers, they feel like they're a failure as a caregiver if we don't eat this much food 3 times a day. I'll lose my job if they find out that I didn't spend an hour and a half feeding this person. But if everybody's on the same page, then this is something that I think will benefit everybody, and it will allow the patient to live the life they want to live instead of being in this condition for years. They'll be comfortable, but they may only last for a few weeks to whatever, a month. Okay? And so, according to the hospice, the goal of a nurse in hospice, the hospice nurse assesses the patient's nutritional status and implements appropriate nutritional interventions as desired by the patient and as deemed appropriate regarding the patient's prognosis and medical history. So based on the job description of a hospice nurse, whether you do the comfort feeding only or the minimal comfort feeding, you fulfill the goal of the nurse. And yet the patient doesn't have to suffer from eating foods that they can't swallow, that they're gasping, choking. The caregivers don't have to feel obligated that they have to feed this small bowl of food and spend hours doing it. And there's less guilt and everything based on the fact that our goal is different. And I think that is probably the best scenario for all of the people involved. But we worked so hard to do something that may not be right. And so when they looked at the patients who didn't get any food or fluids, any discomfort from hunger actually went away after a day or two. So people who didn't get food, they didn't go hungry and have discomfort for the whole duration. Usually the symptoms turned off after a day or two.
Mm-hmm.
So this scenario actually will work very well for people, and they won't suffer. So I think that makes a lot of sense to me. So, that's something that we can educate families and caregivers.